Good morning. This is Dr. Janani. I'm Assistant Professor OBG in Lakshmi Narayana Institute of Medical Sciences. So today my topic will be genital prolapse. You know very well. Genital prolapse is the prolapse of uh, so it's a downward descent of the uterus or the vagina through the introitus. So what are the structures which are anterior will be the bladder and the urethra. So posterior will be rectum and bowel. If these ligaments which are holding bladder and urethra anteriorly are weak, or the rectum and bowel holding ligaments are weak, these organs can also prolapse through the vagina. So, if the bladder is getting prolapsed, that condition is called cystocele. If urethra is getting prolapsed, that is called urethrocoele. If rectum is involved, that is called rectocoele. And bowel, if it is collapsing, that is called enterocoele. We can see one by one clearly. So, what are the levels of uterus support? So, there was level 1. This was a cardinal and uterosacral ligament complex. This is suspensory axis. What it suspends is, it suspends the uterus on the cervix at or above the level of ischial space. Normally, cervix will be at the level of ischial space. So, it always suspends the uterus with the cervix at the level of ischial spines. Okay. So then comes the level 2. Level 2 is the middle compartment. Level 1 is the apical support. Level 2 is the middle compartment. Middle compartment is endopelvic fascia. So endopelvic fascia, if it is in the anterior, that is called pubocervical ligament. If it is in the posterior, that is called rectovaginal fascia. So it will connect the vagina to the lateral pelvic wall through white line. That is, white line is called arcus tendinous fascia pelvis. So the types of cystocele is always divided into two. Why? Because if there is a defect in the endopelvic fascia, that is the middle compartment, that is called central cystocele. If there is a attachment, if there is a weakness in the white line. So white line is always in the lateral. So lateral support, if it is weak, that is called lateral cystocele. So this is the difference. So if the endopelvic fascia is defective, that is called central cystocele. And if the lateral support is weak, that is called lateral cystocele. So we have to always find out which type of cystocele and we have to correct it accordingly. If there is any defect in the if your diagnosis is wrong, then the patient will always come with the same complaints. And level 3 is the levator ani will be in the anterior and perineal body in the posterior. So you can see very well. So level 1 is the apical support, which is cardinal and uterosacral ligament complex. Level 2 is the middle compartment, that is the endopelvic fascia anteriorly, that is pubovesicocervical ligament, and rectovaginal fascia in the posterior. Level 3 will be anterior levator ani and perineal body will be in the posterior. So these are the supports you can see. This was the transverse section. So this I told you, this was a paravaginal defect. See, you can see that this arcus tendinous is called white line. Always this connects the vagina to the lateral pelvic wall through white line, that is arcus tendinous fascia pelvis. If this is defective, this can lead to lateral cystocele. Always you should find a difference between central cystocele and lateral. Central cystocele, there won't be any vaginal sulcus. When you are examining, there won't be vaginal sulcus. But if the vaginal sulcus is there, that is lateral cystocele. So you should find a difference between lateral and central cystocele and repair accordingly. So what are the factors? What are the causes? What are the causes? Most common will be obstetric cases. So, if the patient is being managed widely during labor or puerperium, then it can lead to UV prolapse, uterovaginal prolapse, and menopausal atrophy. Due to the menopause, that is hypoestrogenism, there will be laxity of ligaments which is holding the uterus. That can lead to the weakness of the pelvic supports and leading to prolapse of uterus. And also, if there is any congenital weakness of endopelvic fascia or pelvic floor muscles like spina bifida. That and all will cause prolapse. And raised intra-abdominal pressure. If the patient is having chronic cough, that also leads to the weakening of or laxity of ligaments. And also predisposing factors like smoking, chronic cough, and constipation can also predispose to uterine prolapse. So we have to quantify the pelvic organ prolapse because we have to always find out the defect in the where is the defect, that is anterior or posterior compartment or middle compartment, we have to correct accordingly. So POPQ quantification is universally accepted for describing the anatomical position. So how does it work? So this is A. These are mainly of 9 points. So 9 points, we are taking reference point as hymen. So always you will take reference point as hymen. And AA is from the hymen to the 3 centimeter above the introitus in the anterovaginal wall is AA. And from the 3 centimeter till the total vaginal cervical length is BA. This is always the most dependent portion in the anterovaginal wall. If the anterior vaginal wall prolapses there, that first coming position will be always BA. So always whichever is inside, that will always come in minus. If it is outside, that is all coming in plus. Okay, so AP is same like that. Hymen towards 3 centimeter above the introitus in the posterior vaginal wall. From that to the total vaginal length will be the BP. And C is the cervical leading point of cervix. And D will be the wall, that is posterior vaginal fornix level. And also genital hiatus is midpoint of the urethral meatus to midpoint of hymen. From the midpoint of hymen to mid-anal point is perineal body and tibial is full total vaginal length. Okay. So you can see genital hiatus is from mid-urethral meatus to mid-hymen. From hymen, mid-hymen to anal opening is perineal body. So these are the points. So I told you A is anterior wall 3 centimeter from the hymen. A is most dependent portion and C is the cervix and D is posterior fornix. If the hysterectomy is done, there is no point as D. Okay. So AB is posterior wall 3 centimeter from the hymen and BP is most dependent portion of the posterior wall. So these are the stages of pelvic prolapse. So stage 0, that is no prolapse. All the points are at their level only and there is no prolapse, stage 0. Stage 1 is the most distal portion of the prolapse is more than 1 centimeter above the level of the hymen. And stage 2, the most distal portion of the prolapse is less than 1 centimeter, proximal or distal to the plane of the hymen. And stage 3 is most distal portion of the prolapse is more than 1 centimeter below the plane of the hymen, but no further than 2 centimeter less than the TVL, that is total vaginal length. And stage 4 is complete to nearly complete eversion of the vagina. And the most distal portion of the prolapse protrudes to at or more than or equal to plus TVL minus 2. This is very easy to understand. They will give you with confusing words, nothing. For stage 1, here, what is they are telling is there is the uterus has prolapsed, okay, but not up to the level of hymen. That is, it has come below the level of ischial spines, but not up to the level of hymen. Stage 2 is that uterus is at the level of hymen or at the level of hymen. We will know like that. At the level of hymen is stage 2. Stage 3 is what they are telling us. So TVL minus 2 is what? TVL is 10. So 10 minus 2 is 8. Okay. So less than 8 centimeter outside the introitus, that is, if it is 6 centimeters outside the introitus, 7 centimeters or 5 centimeters outside the introitus, that all comes under stage 3. If it is stage 4 means complete eversion, that is called, you are telling us precedential. What they are telling is TVL minus 10, that TVL minus 2 more than. So what they are telling is, so TVL minus 2 is 8. So more than 8 centimeters, it is out. That is called precedential. That is called complete eversion. That is stage 4 prolapse. Okay. So this is what they are telling. So that is a normal, and first degree prolapse is midway between skull spine and the hymen. Second degree is at the level of hymen. Third degree is outside the hymen, but TVL minus 2 less than TVL minus 2. It is more than TVL minus 2. So okay, this is third degree UV prolapse. So what is this? This is decubitus ulcer. Why decubitus ulcer occurs? Because when the vagina is out, okay, when the vagina or uterus is out, what happens is there will be compromisation in the venous return. What venous return, if it is compromised, there will be venous stasis. Venous stasis, if there is prolonged venous stasis, there will be formation of ulcers. This will cause decubitus ulcers in the prolapse. Always you should treat the decubitus ulcer, then only you should operate on the patient. You should not operate on the patient when there is decubitus ulcers. So what are the types of prolapse? So types of prolapses, I told you before itself, anterior wall, posterior wall prolapse, and apical prolapse. So anterior vaginal wall, what are all the structures in the anterior vaginal wall? So before that, we can see about wall prolapse. Wall prolapse is what is after hysterectomy. If there is any defective in the procedure in the hysterectomy, what happens is the descent of the vaginal wall through the vagina. It is wall will prolapse. Okay. So the vagina after hysterectomy is wall prolapse. It is more common in total abdominal hysterectomy. Okay. The anterior vaginal wall. So if there is upper part of the anterior vaginal wall is prolapsing, that is called cystosis. So that is anterior 1/3. It is prolapsing. That is called cystosis. If the posterior, that is posterior lower part of the anterior vaginal wall is prolapsing, that is called urethrocoel. If there is complete anterior vaginal wall prolapse, that is called cystourethrocoel. Posterior vaginal wall prolapse. So if it is the upper part, that is called enterocoel. If the lower part, that is called rectocoel. So while you're examining, if you are examining posterior vaginal wall, you should always put your sim speculum in the anterior vaginal wall, and you should always lift the anterior vaginal wall to examine the posterior wall. If you are examining anterior vaginal wall, you should depress the posterior vaginal wall and you should examine. So, if you are examining rectocoel, you should always put your sim speculum in the anterior and you should depress the anterior structures, and you will take the patient to strain. You have to see the bulge where it is present. If it is present upper, that is called enterocoel. Middle, if it is called rectocoel. So it is enterocoel. So how we will find the difference? Though I told you upper part, that is enterocoel. If it is lower part, that is rectocoel. So enterocoel is due to weakness in uterosacral, but rectocoel is due to defect in the rectovaginal fascia. Okay. So what are the symptoms? So symptoms can be always the patient will have difficulty in evacuation of fecus, and patient will always tell the classical symptom that she has to push the rectum backwards to pass fecus. And signs will be the posterior fornix will be the mass will bulge in the posterior fornix and upper posterior vaginal wall, and also positive impulse will be seen and the cough impulse test will be positive, and swelling is reduced by gurgling sensation due to small bowel contents, and the swelling is out of reach. That is get above the swelling is always present. So soft reducible mass in the lower part of the posterior vaginal wall, And the swelling increased by cough and straining and compressible with no gurgle. Gurgling sound is always present in the enteroseal because enteroseal is bowel content. So if there is bowel content, that will be gurgling sound. In case of PR examination, always there will be get above the swelling will be present. There is in enteroseal there won't be any gurgling. Sorry, get above the swelling. So how the patient will prove? Classical symptom will be mass protruding from the vulva and back pain. Back pain, how it is occurring? Because due to the chronic exposure of the weakening of uterosacral ligaments, there will be stretch in the uterosacral ligament, which will cause stretching of the sacral nerve and which causes the back pain. Because of the stretching of uterosacral ligament, pain occurs. And also, due to the cartilage vagina, patient will have sexual unsatisfaction. And because of that congestion, there will be pain, bleeding, and discharges may be present. And because of the chronic prolapse of the cystocele, there will be symptoms of UTI. So urine will get stasis, and there will be symptoms of UTI like loin pain, fever, rigors, and vomiting. And this case is difficulty in defecation. So always when you're operating, should always perform bladder testing. So you should screen for UTI and post-voidal residual urine volume and present or absence of bladder sensation. Okay, always you should have stress testing perform with the prolapse reduction. Always you should reduce the prolapse and you should tell the patient to cough. If the cough test is positive, you should always perform stress urinary continence surgery also, because if the patient's symptoms is not reduced, she is again come with the same complaint and sue you. So always you should check for stress urinary incontinence also. So stress urinary incontinence, how you will check? You should reduce the prolapse and you should not tell the patient to empty her bladder. You should tell the patient to fill her bladder and tell her patient to cough. If there is any leakage of urine, you should see your stress urinary incontinence. Stress urinary incontinence, what is the treatment will be? This slings can be or TVT tape can be put. TVT prolapse or TOT prolapse, TOT tapes. Okay, that is transvaginal tape or transobturator tapes. Or if you are doing laparoscopically, that surgery will be burst corpo suspension. So what you will do is the bladder neck will be suspended at the level of the pectineal ligament, which is the strongest ligament. So, special test will be bimanual to detect a adnexal mass. So, PR is to differentiate enteroseal from the rectocele. And I told you post-voidal residual volume, you should check if it is more than 100 ml. That indicates that patient is not completely voiding and it indicates incontinence. For diagnosis will be, I told you, so anterior compartment, you should always, shrimp speculum will be retracting the posterior vaginal wall and look for cystocele. And also you should look for cystocele or central cystocele or lateral cystocele. I told you, lateral cystocele, there will be vaginal sulcus will be present, but central cystocele, there won't be any vaginal sulcus. And also you should look for stress urinary incontinence. Nodal compartment, you should see degrees of prolapse and how much degree and how much keratinization is there or ulceration are there. For posterior compartment, you should always retract anterior vaginal wall and if there is bulges from above downwards or below. So this is how we will examine. So investigation, what all investigations will be done for surgeries? So normally hemoglobin and urine culture and examination, neurodynamic studies and high vaginal swab in case of vaginitis, and also ultrasound to rule out any abdominal masses and intravenous urography in massive flux to rule out hydroerythronephrosis. You should not always operate when there is hydroerythronephrosis, and you should always treat UTA and also hydroerythronephrosis before operating. What are all the DDs? If there is anterior vaginal wall prolapse, there can be DDs of Gardner cyst or inclusion cyst. How to differentiate? you have to put a catheter. So if you're putting catheter, the swelling disappears. That is cystosol. If the swelling does not disappear, that is Carton cyst or some other cyst. Uterovaginal prolapse, DDs will be large fibromatous uterine prolapse or congenital elongation of cervix. So how you will find? You have to put uterine sound. Uterine sound, if you are putting, in case of UV prolapse, its external arch will be visible, so you can pass uterine sound. But in case of fibromatous polyp, you can't pass the uterine sound. And also vaginal elongation of the cervix also you can. There will be only the elongation of cervix, but uterus is at the level of ischial spines. So pseudouterine prolapse is what I told before, that is elongation of only the vaginal portion of cervix with no aversion of vaginal cornices. So how to differentiate it between. It is also done by uterine sounding. Treatment will be by only cervical amputation. So complications will be congestions or incarceration or mechanical disability. So vagina. So when the vagina is staying outside, so what happens is the epithelium will be exposed outside. What happens will be there will be formation of deguta. I told you before, the venous stasis be happening. So there is no proper venous return, which will form ulcer formation in the vagina. So forming decubitus ulcer. For decubitus ulcer, what you will do, always you should pack the vagina, and first you should reduce the prolapse and pack the vagina with betadine. Yeah, you should always do so, because this what it will do is this will promote venous return, and this will not produce the decubitus ulcer, and this will heal on its own by doing always this dressing. So cervix will become congested, edematous and hypertrophied and keratinization. So you take because of urethral kinking and cystosis. So what are the management? How to prevent and treatment? So treatment will be non-surgical and surgical. So how will you prevent? So I told you most common cause will be always obstetrical. So should always conduct the labor properly. So always bladder should be kept empty throughout the childbirth, because the bladder is full and the patient is delivering. What it will happen will be the bladder will be, the ligaments all will be weakened and it will lead to collapse. And also you should always encourage the patient not to bear down before full cervical dilatation. And also you should not apply forceps before full cervical dilatation. And prolonged second stages avoided by doing amniotomy or forceps or vacuum extraction and episiotomy. So always you should properly suture the perineal tears to strengthen the secondary supports. So this is Kegel exercise. Kegel exercise is voluntary contraction of pelvic floor muscles. Why? So how you will do Kegel exercises? How you are holding fecus. That's how you have to do. Always you should do try 3 times daily. That three times is morning, afternoon, and night. In that morning you should do 6 times, and afternoon 6 times, and night 6 times. This will promote the strengthening of the pelvic floor muscles. So if the prolapse is detected in the postnatal period, you should always delay the surgery for 3 to 6 months. Okay. So what you will put is ring pessary will be put, and after 6 months only you should operate on the patient. And also you should always tell the patient to encourage spacing between pregnancies with the use of contraceptives. And also in case of postmenopausal women, who should tell to take hormone replacement therapy. So obesity, what are all the predisposed to obesity? I told you coughing, constipation, and also heavy weightlifting and fibroids. So pessaries, how pessaries work? What happens is pessaries will hold the uterus above the visceral spine. So how you will insert pessary? Before inserting pessary, you should always measure the distance between your posterior fornix. You have to do bimanual examination, and you have to measure the distance between posterior fornix and symphysis pubis. So, because depending upon that, you should tell the patient to buy the pessaries. There will be three sizes available: small, medium, and large. So, you tell the patient to buy. So, after buying, you have to. So, now we will see indications of pessary treatment. So, what are the indications? Uh, now we will see indications of pessary treatment. So, what are the conditions you will use pessary? So, it is always used in pregnancies with prolapse uterus till 16 weeks. And also puerperium till the involution is occurring, that is till 6 months. And also to prior to the surgeries to help healing of the decubitus ulcers in the vagina, you will put pessary before that. And also if the patient is refusing for surgery and in case of old women, you can put prolapse. You can put pessary. So what are the types of pessary? Supportive pessary, that is a ring, jarring and marlin, and space augmented gel horn, donut and cube. So always you will put ring pessaries only. These are the ring pessaries. So ring is always used to insert by folding the ring half and placing a small amount of lubricant on the tip of the pessary to aid in insertion. And it is then placed into the vagina where it unfolds on above the pubic symphysis. And for removal, the pessary is always pulled and folded in half. These are the types of pessaries. So space of in gel horn, donut and tube pessaries. So what will you instruct the patient? Daily vaginal douching will be recommended, and also pessary should be always cleaned, that is removed, cleaned and replaced every 3 months. So the important is to for topical application of estrogen prior to pessary use, particularly if there is if it is a postmenopausal woman. On the pessary in place, so always you should tell the patient to apply a vaginal estrogenic cream. So what are the contraindications? Wide introitus, presidentia, abuse hysterosal rectosis, and infection of cervix, and refusal of pessaries. So these are all the indications of surgery. What are the complications will be? Patient will always have wide discharge, that is vaginitis and cervicitis, ulcerations, and also impaction of pessary in the vaginal wall, and urinary complications and constipation. In some cases, there can occur vesicovaginal fistula. Always surgery is the only curative treatment. So I told you what are all the indications is wide introitus, large cystocele or rectocele, enterocele, congenital prolapse or presidentia, and if patient refuses a pessary. So contraindications will be pregnancy and puerperium, and the patient refuses surgery. So what all the factors to be considered is age of the patient. The patient is has completed her family, or if she wants any fertility preservation, and also if she wants any intercourse and only intercourse, that is sexual life, you have to plan accordingly. So yeah, operative time always immediate post-menstrual period is the good time because this will promote wound healing and also it will avoid the pelvic in congestion and also and also prevent blood loss at the surgery. And it also minimizes the risk of infection. So pre-operative preparation will be you have to clear all the cervicitis or vaginitis and also estrogenic ointment should be used in postmenopausal females. So surgical management, anterior compartment repair is anterior corporography. So what are the steps? Always you have to pull the cystocele and you have to always do hydrodissection. How we will do is, we have to dilate 10 ml of saline in 1 is to 10,000 adrenaline, and you have to mix and inject in the anterovaginal wall, and you have to make a horizontal incision. Horizontal incision, and also you can see clearly. So this is the, so you have to make the in the horizontal incision in the vaginal wall, and vertical incision from the midpoint of that horizontal incision to just below the external urethral meatus, and you have to raise triangular flaps, and you have to cut the vesico-vaginal pubo-vesical fascia, and you have to expose the bladder, and you have to push the bladder up with the gauze, and you should not use any instruments there because the bladder will be injured. And you can see that pubo-vesico-cervical fascia which is exposed, and you have to tighten that. Because of this weakening only there happened a cystocele. So you have to always tighten this pubo-vesico-cervical fascia by putting sutures on the pubo-vesico-cervical fascia. So pubo-vesico-cervical fascia and bladder, and also in the anterior vaginal wall. This is called bladdering buttressing sutures, and you have to close accordingly, and the redundant vaginal wall will be excised. So anterior colporrhaphy, that is to correct cystocele and urethrocoele. The principles I told you, to exercise a portion of the relaxed anterior compartment, to mobilize the bladder and push it upwards after cutting the vesicocervical ligament, and bladder is then permanently supported by plicating the endopelvic fascia under the bladder neck in the midline. The paravaginal repair is to repair the white line. So always you should repair the white line and make it strong by making sutures. So you have to suture that is white line, wherever it is suture, that is white line. So white line is strengthened. So posterior compartment is corrected by posterior colpoperineurachy. So rectocele is always corrected by tightening the pararectal fascia and rectovaginal fascia, and the perineum is corrected by operating on the torn hernial body. So same like that, we have to put 3 ali forceps in the posterior vaginal wall, and you have to raise a triangular flaps, and you have to reduce the rectum or introcele sac, and you have to strengthen the rectovaginal fascia. So enterocele, the principle is obliteration of the neck of introcele by bursting sutures and excise the excess peritoneal sac and approximation of uterosacral ligament. So that is same like that. Bursting sutures will be raised and it will be excised. Apical compartment classification of surgeries will be if the patient wants pregnancy. So all procedures can be put. That is nulliparous products. Always you should put sling surgeries. And if she doesn't want any pregnancy but she wants hysterectomy, so she wants the intercourse, then you can promote vaginal hysterectomy. If she doesn't want pregnancy and also intercourse, you can promote Leapods. So pseudouterine prolapse is congenital elongation of cervix. So always it is treated with cervical amputation. For treating uterine prolapse, there is 3 types. I told you: vaginal hysterectomy, Manchester, or suspension. Suspension of the uterus. How you will suspend is by sacrohysteropexy. For none for women who wants fertility and also to preserve the uterus. So sacrohysteropexy can be done laparoscopically, and also sacrospinous fixation. It can be done unilaterally on the right side. So if it is done on the left side, there will be sigmoid colon can be injured. So always it should be done on the right side. So you will see about the vaginal hysterectomy. Vaginal hysterectomy, the indications will be UV prolapse in postmenopausal women, prolapse associated with other cause of hysterectomy like fibroids, and alternative to other procedure if the family is completed. Always anterior colporrhaphy followed by cervical amputation is done, and always the incision is extended towards the cervix, and you have to open the POD, that is pouch of Douglas, and you have to start clamping. First clamp will be put on uterosacral and second rods ligament complex, then uterine artery, and lastly with the round ligament and cornu-fundal structures. So then, in cases of sacrocolpopexy, before she wants to preserve her uterus, you can do sacrocolpopexy laparoscopically. So this is allows the upper vagina to regain the anatomical axis. So the mesh is cut in the shape of Y. So that Y, two limbs of Y will be placed in the anterior wall of the uterus, and the Y shaped, that the horizontal limb of Y will be placed in the sacral promontory. So that will support at the level of S1 and S2. Can be performed laparoscopically or robotically. So sling is always indicated in conjunction of nulliparous prolapse without cystosis. So meshes can also be preferred. So further this it is to correct the uterine design associated with cystosil and rectosil. So first is to do DNC, and also to uh, perform anterior colporrhaphy and amputation of cervix, followed by fixing of the ligaments, and followed by posterior colpoperineal. So modified Fothergill's operation is done without cervical amputation to prevent cervical dystocia. Because if we are doing cervical amputation, there is a high risk of cervical incompetence during her pregnancy. That is why cervical amputation is not done nowadays. So sacrospinal ligament fixation always perform on the right side to avoid the sigmoid. You can see that the upper vaginal wall is secure to the sacrospinous ligament. This is the vaginal hysterectomy. So leaf force is always done for patients who are not sexually active. So what happens is the patch of anterior and posterior vaginal wall, vaginal mucosa is removed, and it is sewed to that is it will be sewn like that. So there won't be any space for intercourse. So all the vaginal walls will be opposed, and there is no space for intercourse. Main problem is limitation of coital infection, so coital function, and also others will be if there is any bleeding, so that will be all hiding in the behind that vaginal wall. Sacral ligaments especially can be used prophylactically or at hysterectomy or therapeutically for vaginal apical suspension. So intraoceal repair is by Meckel's caldoplasty. So there will be internal and external Meckel's cardoplasty. So always you should diagnose and treat stress urinary incontinence before operating. And if there is stress urinary incontinence is there, you should always do concurrently with uterine prolapse. All the patient will be having same complaints after hysterectomy. So what are all the post-operative care is? You have to for postmenopausal women, you should give estrogen, and also advise to resume pointers within 2 weeks, because to avoid over tightening of the vagina, and also temporary vaginal packing for at least 24 hours. And if she is getting pregnant, then she is to be delivered by C-section. Side effects are dyspareunia and recurrent condition, which can be due to the wall was not sutured to uterosacral ligaments. So that wall can be prolapsed by vaginal prolapse, that is called wall prolapse. Or recurrence of prolapse is due to persistent predisposing of vaulted technique, because before I told you vault is not sutured to uterosacral ligament, that can prolapse, or if there is any infections, right?